Okay, well, thank you to the organizers for...
Dr. Jeff Powis.
Oh, okay, get an introduction as well. So you can tell I'm hungry, and I'm the last barrier between you and lunch. That's why I was moving so quickly ahead of this. But I wanted to talk to you today about treating the difficult to treat. And again, it really picks up on Jason's presentation as far as the need to better deliver care for Hep C patients, particularly those who are difficult to treat. So as you know, most new Hep C infections are related to illicit substance use. It's thought that 70% of the incident infections in Canada are attributable to illicit substances. As has just been outlined and in prior work by Dr. Greebley, we know the treatment uptake in this population is extremely low at around 1 to maybe 2%. Additionally, we know that providers who provide care to our patients living with hepatitis C are reluctant to treat patients who are active substance users. In a survey done of physicians who treat Hep C patients, only 19% of them were willing to provide treatment for somebody who was actively using substances. My own experience with it, the traditional hepatitis care delivery model of a hospital-based clinic or an office-based clinic, was that very frequently the patients that I wanted to get to care didn't even come to see me. And if they did come to see me, they frequently were lost to follow-up, unable to follow through with follow-up appointments with myself or additional investigations required for the workup process. The small number I was able to get to treatment, I found them quickly falling off with respect to my ability to deal with the complex medical, social marginalization, and mental health issues. As a result of this inadequacy of the current models, we moved forward with developing a community-based program. So the Toronto Community Hepatitis C program is a collaborative community-based model of Hep C treatment and care delivery. It uses a group as the core of the model, and patients are throughout the group process engaged in their care provision. It started in 2006, and it's a partnership between 3 community health centers within Toronto, all of them in areas where there are high prevalence of patients using illicit substances. Myself, I help mentor the primary care physicians in the treatment of hepatitis C, and Dr. Sokolingam assists with the mental health aspect of things. He's a psychiatrist that works at the Liver Institute at the Toronto Western. We don't have any addictions specialists, although the primary care team are very adept at dealing with addiction issues as they arise. But we don't provide any opiate replacement therapy. Our major focus is on harm reduction underpinnings. So as I mentioned, the group is the core to our program. We try to do all of our services on site. And prior retrospective work has shown that we were able to achieve a similar treatment initiation compared to other clinical cohorts, and with equal adherence and clinical outcome. This schematic represents our program. We've kind of thrown it in a house here to show you that everything is on site. Patients have to leave very infrequently for specialist referral. Occasionally, if we have a nearly decompensated cirrhotic, we'll send them to the Toronto Western Hospital for assessment, or occasionally other specialist referrals may be needed to be done off-site. But for the most part, everything is provided on-site. The group is at the center of the model, and the Patient Advisory Board has been very important to help direct our research and our program direction. So our study was a part of a larger prospective study that was designed to evaluate the treatment outcomes and also the psychosocial outcomes of our population who participated within the Toronto Community Hepatitis C program. Today I'm going to report for you the baseline demographics. We're still doing our follow-up prospective evaluation of this cohort, and so that data will come in the future. So the major thing that we did was provide questionnaires to patients who participated in at least one group session. It began in 2011, and the survey tool included as much as possible validated tools within this population. But again, as many of you know, many of the standardized tools have not been well validated in patients who use illicit substances. We used PHQ-9 and GAD-7 for depression and anxiety, respectively, the Addiction Severity Index, and the Medical Outcomes Study Social Support Scale to give an assessment of how much support these individuals had in the community, and received REB through the University of Toronto. So we had 81 unique individuals who had the survey administered. The survey was administered by a research coordinator to potentially get any barriers between, with respect to patients being unable to read or participate in the questionnaire if done independently. So most of our patients were male. The average age was 48. Most of them were white. We don't have that statistic there, but the majority were white. Poverty was prevalent. I mean, 89% of our patients had a mean income of less than $2,000 per month, and 82% of them, the primary source of income was social assistance. And when the research coordinator was telling me that somebody on Ontario Works makes around $600 a month and on a disability is $1,100 a month, that it really highlights how much poverty there is. 46% of them were unstably housed. In the last 6 months, 36% of them did not have enough food to eat. 49% had less than a high school education. As is common in Toronto, the major drug of abuse is crack cocaine. And the majority, 52% of our population, had used crack in the last 6 months. Injection drug use is much less common in Toronto than it is in other areas, but only 19% of our patients had used that in the last 6 months. A lot of mental health comorbidities. Often we talk about this trimorbidity of Hep C, mental health comorbidities, and polysubstance use. And a substantial proportion of our population, 40%, had a prior hospitalization for mental health. On average, 12 years between the time of their diagnosis. And again, there may have been delay in diagnosis between the time of assessment. And I think this last statistic really highlights the stuff we just heard from the previous presentation. Only 15% of these people had ever had any attention paid with respect to a physician assessment for their Hep C. And this question, the way it was worded, is it could have been a primary care doctor or any medical professional, not necessarily somebody who is skilled in delivery of Hep C care. So not only do they have this, poverty and other issues, they also have no one to really support them in the community, or very little social support. So the MOSS score, lots of S's, was 56.68, which if you look at other chronic diseases, particularly some work that Dr. Suckalingham did with bariatric patients, the MOSS score is about 2 times that. So there's very little social support for these individuals. There's moderate levels of depression with a mean PHQ-9 of 10.45. In the GAD-7, there was mild amounts of anxiety. We use the ASI to try and assess how severe their addiction, it's called the addiction severity index, their substance use was. And so on average, there were 5.5 days which were quote-unquote problematic with respect to substance use, and around 3 days with respect to alcohol. In the last 30 days, 44% reported depression, 69% reported significant anxiety, 15% reported violent behavior or never thoughts about going forward with violent behavior. 7% had suicidal thoughts, and one client in the preceding 30 days had a suicide attempt. So you can see through this data that the population served by the Toronto Community Hepatitis C program is highly marginalized, with high rates of unemployment, substance use, mental health comorbidities, and poverties. Our current care model for provision of Hep C care, for the most part, isn't able to support the complexities of this population, and we need to develop new models of care provision for these patients. The Toronto Community Hepatitis C program is certainly a promising model, and I hope that our future research will help highlight that. What we've done to date is some retrospective work, which again has shown that we were able to get patients to treatment and through treatment equal to what would be seen in large randomized trials. Dr. Suckalingham did some work of our cohort that looked at patients with severe mental health issues. Those are people with a prior history of suicide attempt or severe depression, mental health hospitalization, and showed that the outcomes for those individuals were the same as the outcomes for patients who did not have those characteristics, with appropriate mental health support throughout treatment. We did qualitative work which highlighted the program structure and group cohesion as really pivotal key points to induce individual change. And Dr. Woolhouse entitled her paper, "It Gives Me a Sense of Belonging." And again, I think that's what the group does for many of our clients. And lastly, Dr. Suckalingham is working a little bit on evaluating our group cohesion. And as mentioned earlier, group cohesion is really paramount in knowing the success of a group and engaging patients in treatment. And our group cohesion was very high, and we had very few dropouts, around 19%, which for those of you who do any group work is quite a good dropout rate, especially for a complex patient population. So thank you for your attention. I just wanted to acknowledge a few people who assisted with this research. Kate Mason, who is our research coordinator, delivered the questionnaires and did a lot of this analysis. Chris, who helped out with the statistical analysis. And probably most importantly, our patient advisory board, who really helped drive a lot of our research direction and also our programmatic direction with respect to the development of our program. So thank you for your attention.
All right, so we have time for one quick question.
But we know you're hungry.
We do know you're hungry, but then I'm going to ask a quick one.
I'm just joking.
And I'm just curious, Jeff. Nice work. It's really great, all the work that you guys have been doing in Toronto. The one question I have is, so one thing that we're all struggling with is sort of how do we sort of enhance assessment in this population, and moving towards kind of the treatment care cascade that I was kind of explaining. And do you have any insights as to some of the strategies that you guys might use with the incoming sort of interferon-free regimens when things get a little bit simpler, easier? We get rid of the toxicities of pegribavirin, telaprevir, boceprevir.
Yeah, so I mean, the first comment I'd make is that I think your insights about it doesn't matter if we only get a small proportion of people, it doesn't matter how good the treatments are. If we get a small proportion of people to treatment, it's of no value. And again, my own clinical work in HIV really highlights that the patients are not doing well in an era where we have effective therapy, are those that aren't able to access or adhere to therapies appropriately. I think engaging them with respect to engaging them in their own health through that education and the group really, for me, is what changes on an individual perspective. And that takes a lot of hard work and time in the trenches to develop the relationships with the clients. Involve your peers, because they're going to help with developing ideas and give you that kind of, I talk about my street cred as far as allowing the program to work.
Lauren just has one quick question.
Yeah.
My question is that many of these patients are the same patients that have HIV. And what is the treatment rate of HIV compared to hepatitis C in the patients in Australia, Toronto, any place else?
I don't have the number off the top of my head. I don't know if anybody else here, Curtis, may have that available, or Maria.
I know.
I think your point, Lauren, is that we actually do quite well with HIV in many of the same patients. So we have, in our cohort, 80% of people have been on antiretrovirals, 65% of them have an undetectable viral load. So, and they manage to do quite well long term.
My point
I was
is
going to add the same thing. I know that Brian Conway's program in Vancouver has, they've been demonstrating that it's very, you get long-term viral suppression in this population, and a large proportion can adhere to treatment and do really well.
So, there has to be a question here. Why do we do so well with HIV compared to hepatitis C? And now that we've got therapies that will cure rather than chronically suppress, shouldn't we be doing better?
Great. Well, that's a great ending to the session.